a friend who had a list of questions, unfortunately had to leave early. So I guess, but then I have got some questions, so can have some little discussion first on carotid endarterectomy. Yeah. So of course, just something about the surgical techniques. So here you use continuous sutures, not interrupted. Okay. And you always advocate a shunt for endarterectomy.
Yeah, I personally do selective shunting. So what happens is that number one, actually, before I go in, I'll actually look at the degree of collateralization. So number one, the contralateral, whether there's a good PCOM, whether ACOM and PCOM. So that will actually help me to tell me whether when I cross clamp, whether I really need a shunt or not. So that's number one. Then number two is obviously all the neural monitoring. So if the signals are dropped, then I'll start the shunt. But
have you had such instances where you had to put in a shunt in between because of drops of?
Yes, definitely. So then we will prepare, especially if it's going to be one of those contralateral ones, but unfortunately not able to go for CAS, that group. Yep.
The other question was about aspirin. Now we heard this session and the session before. So aspirin is continued, right? Patients do not stop.
That's right. I don't stop aspirin.
So that is something I wanted to discuss in the open house. So what is the neurosurgery policy regarding aspirin? We have cases of moya, we do vascularization, we do endarterectomies with patient on aspirin, we do not. But for other tumor surgeries, other general surgeries, the anesthetist often recommends that you stop aspirin. So what is the general consensus in the policy? I personally do not stop aspirin at all. Clopidogrel, yes, it's a no for me. But aspirin, a patient is on the most common indication problem comes when chronic subdural hematoma is an elderly patient, and they invariably would be on antiplatelets and clopidogrel. So what is the?
So I'm happy to operate any surgery on aspirin if there's a good indication for the patient to be on aspirin. But in Australia, you often find people who are just taking aspirin because they think it's a good idea. It's probably not a bad idea. But if there's no good indication for aspirin and it's elective surgery, I will cease it. But if there's a good indication, then I'm very happy to operate any surgery on aspirin.
Yes, all the faculty agree on that. Nobody stops because we have interesting scenarios where we do a decompressive craniectomy for an MCA infarct, and then patient is put on aspirin and he comes back for cranioplasty. Then we ask them to stop aspirin. And last question for you on timing of. You said something about 2 weeks. So is it a hard and fast rule or?
Yeah, the guidelines is really try to do it within 2 weeks. So my anesthetist is used to me listing, let's say, post-stroke and cranial and doing CEA as an elective comeback. But more and more nowadays, we are trying to do it as early as possible. Sometimes.
So have you done emergency endarterectomies?
Not only with his crescendo TIAs and you already see thrombus. But even then, there was that discussion with my neurologist whether just anticoagulation or not, rather than straightforward carotid CEA itself. So number one, but most of the time we try to do it within the 2 weeks of stroke.
And especially if it's an ulcerated plaque, I guess you better not wait. Questions for you, Professor Azmi. I mean, I haven't done as many as you have, but whenever I found done endoscopy for post-infection, I find I'll get lost because ependyma and all is so friable. You have white flakes all over. I just cannot sometimes identify which is the foramen and so forth. Is that a common problem or it is something with my technique? I got lost inside the ventricle in post-infectious cases many times.
Most important thing to look at the images before surgery. So from there you can see the pus accumulated at certain area. So usually I go the frontal horn first, and then I go towards the septum. Then once I see normal ependyma, then because that is the surface part, even though you damage, it won't be any effect. Rather than you go lateral because thalamus or your striate vein all are there. So then we go slowly. Then once you get like a normal ependyma, then you move towards that. But of course, there are cases where the ventricle can be very friable. You have to be selective too. So rather than trying to attack all the slough, so at least to change the fluid as much as possible, and sometimes you can do a stage rather than one off. So we have case where we use about 6 liter or 12 liter of Hartmann solution, took us about 4 hours. Very bad pass. So finally we managed to get it done, but again we have to repeat it again 1 week later.
That was my second question. Normal endoscope, ventricloscopes have a channel for irrigation and for section. So you use this, your aspirator through that instrument port. So that's a separate irrigation port that you use.
No. So you use, if you look at the Minop, they got 4 working channel,
Okay.
4 channel and 1 working channel. The single working channel is where we put the suction.
Okay.
We must make sure that the water in and water out using the same channel.
Okay.
And the working channel is only to aspirate the slough.
Right, the nasogastric tube is through the working
Yes.
channel. And so the scans which you showed had sediments and pus coming, you could aspirate the pus. So what is the timing of your intervention? Because normal infection, CSF, infection comes, our first tendency is to put in a ventricular drain. So at what point do you decide, okay, now it's enough, I'm going in with ventricle, with the ventricular scope?
Normally, I don't rush. So child usually sepsis. So they are unstable, they are in ICU. So minimum put an EVD first, unless the patient already have shunt or whatsoever. And once the child is stable, and then we bring to theater. So we get a contrast so that we can see where is our safe target. So there are only a selected case where we go in immediately, but some we wait a couple of days, give antibiotic first, optimize, and then we rush to surgery. And we sometimes we do even emergency at night for selected cases, especially if the child really in critical state. But once the BP okay and fevers sometimes very high, so we have no choice. We go in and immediate post-op, you can see dramatic change in terms of the fever.
Okay, thank you. Professor Vincent, you wanted to?
Doesn't ask me. One problem I face for the neuroendoscopic IVH problem is the issue of post-removal tractal hemorrhage from the access. For example, in infectious cases, the brain is cerebritic and it's very friable. So when you remove that splat, and even for IVH case, no infection. But the trouble is that after that, the tractal hemorrhage continue and woos back in. What do you do? Do you have any tips and tricks on what do you do about that? Thank you.
You mean bleed along the tract? Okay, this is very important because as you introduce your scope, you have to make sure that your trajectory are clear from hemorrhage. So sometimes I spend time a little bit to make sure the tract is clean first. So what I do is a combination of sometimes bipolar or the tip of endoscope. The endoscope is actually pretty hot. So you can do a contact, you touch it and irrigate, it will stop. Okay, so once you get that, you go in. This is very crucial because if your tract bleed again, and then the game over. It will start back to have IVH. So I actually show in one of the slide, but very quick, so that we withdraw and then we make sure that it is clean. Then only we take out. So don't rush to remove it. Give some time and examine again. So I think that's what we do.
Thank you, Professor Asmi. And the VNS, as you told, is it's a palliative surgery. It had a rise and a fall, and it is again coming up. And no comments and questions about VNS. This is one last final on MBD. So, Dong, and how you said diagnosis is based on neurovascular conflict. Is that a mandatory criteria for you to operate on patients, or it's a clinical diagnosis? Because earlier, before neurovascular conflict came, it used to be a clinical diagnosis, but now there's a lot of emphasis being given on MRI diagnosis of a neurovascular conflict before going in for surgery for MBD.
Before surgery.
You
yeah.
depend on, is that a
Yeah.
mandatory criteria for you? No.
It is nowadays I think there are some problem with the MRI I see many patients with the headaches, sometimes and only headaches, but on MRIs, the radiologist they think, oh, the eye contact, there's a vascular complaint, something on the 5th, on the 7th even, oh, I don't know. But for me, the most important thing is clinical sign. Yeah. We do MRI before surgery, but it's not the key. The key is the clinical sign.
Thank you, Professor. May I hand over the mic to the organizer and ringmaster.
The ringmaster. So we'll bring the conference to a close. Thank you for the attendees. Thank you for Professor He for hosting. I was looking through my photos and it's really exactly this time that we were here before. Was it 8 years ago? 2015, 7 years ago. And it's just as wonderful a time. So thank you for having us. I'm really impressed by the quality of the questions, the standard of the presentations. Clearly, Vietnam neurosurgery has a very bright future. And we'll look forward to hopefully being back again, hopefully not 7 years this time, sooner. And also thank you to our Brain Lab colleagues for all your organising. Yes, especially Tin and where's Gabrielle? He's gone. Oh, there he is. Tin and Gabrielle. But to the whole team.